Dr. Vinod Arora is going to speak on, he's a chief and presenting author, comparing outcomes of transepithelial surface ablation to femtoLASIK for high myopia surgery. All yours, sir.
Thank you. Good morning. So my topic is today comparing outcomes of transepithelial surface ablation to femtosecond lasing for high myopia surgery. The purpose of study is to compare the one-year outcomes of transepithelial surface ablation with femtosecond laser for high myopia surgery. In this retrospective study, data was collected from 256 eyes of 135 patients. The two study groups were matched by age, gender, and baseline undercorrected visual acuity and refractive astigmatism. The instrument used are the wavelight allegretto laser and AIOS2025 were used for femtosecond laser, and streamlight from wavelight was used for transepithelial surface ablation. The number of cases were 256, out of which 150 were femtosecond lasing and 98 were transepithelial surface ablation cases. The femtosecond, the amount we taken for myopia was 6 to 10 diopter in both the cubes, and the maximum cylindrical amount was 4 diopter. So the total spherical correction was not more than 10 diopter in these cases. So best corrected acuity we achieved in femtosecond lasik in 3 days, while in advanced surface ablation it was on 10 days. Major complications were practically nil in both the studies. Minor complications were there which were resolved itself. These are almost matching. Then post-operative visual acuity in 156 patients, we were able to achieve better than equal or better than BCVA's 148, that's 95%. In advanced surface ablation, it was 98%. So the corneal refractive surgery includes microcotome surgery, femtolasic surgery, SMILE, and advanced surface ablation. PRK1 almost got abbreviation, has come back to as advanced surface ablation. The game changers are mitomycin, the newer wavefront optimized epithelial removal system like SmartSurf or Streamlight. The study demonstrated that ASA has a good outcome for high myopia. Its range is as good as of that LASIK or SMILE, being more tissue preserving and better biomechanical safety. Advanced surface is gaining popularity. Our result shows that one-year result with both the techniques are comparable. However, the transepithelial advanced surface results are marginally better than femtosecond laser. The surface ablation is one of the most effective tools in the surgical armamentarium of the refractive surgeon. It is still underutilized, but is a very promising and exciting with superior results. Thank you. These are my references.
Very well said, sir. Little restriction on the powers we can cover up in transepithelial, but otherwise it's one of the very promising.
Yeah, see, the Alcon has recommended up to 10 diopter spherical correction. Of course, for over 8, we prefer ICL, but some of the patients which are not fit for ICL or doesn't want to pay much that much amount, then they go for LASIK also. Some patients don't prefer lens surgery, maybe for some reason.
So do you do the epithelial marking and mapping in all the
Yes.
cases, and do you take that into
That's
consideration?
important, you to know the epithelial mappings.
Your results have been very promising.
There's the flip side, you need a OCT which can measure epithelium, and second, there is a per procedure fee in this also.
How do you rate it with PTK and PRK versus a transepithelial?
Basically, the pattern of removing epithelium is totally different. If you do PTK, there is a myopic thing is there. While in this is an optimized removal of the epithelium, so it's a neutral removal of the epithelium as such. So you don't got anything. And second, being very smooth, it makes the healing very, very quick and very smooth that way. So it's much superior to what we call a transepithelial, PRK such we call it. It's much, much better than. The basic thing is here, the removal epithelium is different. It's a wavefront optimized in this one.
Correct.
While this is a planar one in other PRK.
Correct, sir.
Any complications or any surprises you saw in your series?
Practically there were no complication as such. Of course, there was recovery slow. There is a more pain that compared to LASIK, but that's been explained to the patients. And we make sure the patient avoids UV lights. he has to use UV goggles that we provide himself, not from the market, and that has to be used for 3 months. And if he's going to high hills or is going to beach, then again is to use these glasses.
And how long did it take for the epithelium to heal in your series? You said slow healing.
Normally on we see on the third day it's totally covered.
Okay. Thank you, sir.
All right, thank you, sir. Can we have the next speaker, Dr. Ishita Pandey, please? And she'll be talking to us about first Indian results of femto LASIK with shrimped ATOS for myopia and myopic astigmatism.
Good afternoon, everyone. The topic of my study is first Indian results of femto LASIK with shrimped ATOS for myopia and myopic astigmatism. There were no financial disclosures. Although several studies worldwide have evaluated femto LASIK outcomes, limited data exist on the Schwind-ATOS system specifically. To the best of our knowledge, no research has been conducted on its performance in Indian patients till date. The aim was to find out the visual and refractive outcomes of femto LASIK with Schwind-ATOS for myopia and myopic astigmatism in Indian population. Study design was prospective observational study, population being patients who underwent femto LASIK at our center, and Schwind-ATOS was used for flap creation, and Schwind MRS 500E examer laser was used for stromal ablation. Inclusion criteria with patients with myopia and myopic astigmatism who underwent femto LASIK with Schwind-ATOS and who had at least 3 months of follow-up. These were my pre-op refractive ocular examinations that are done routinely at a center. This is the Schwind-ATOS machine used for delivering the laser for flap creation. So final post-op refraction at 3-month follow-up, prediction error, efficacy and safety index were calculated. These are my statistical analysis. Results, a total of 100 eyes of 55 patients were taken into consideration. Distribution of myopia severity were 21% mild, 45% moderate and 34% high myopia. The UCVA of 20 by 20 or better was seen in 82% of eyes at 1 week post-op and 86% of eyes at 3-month post-op. Now comparing the pre-op and post-op 3-month visual and refractive outcomes, the UCVA improved from 1.03 to 0.06 logmar, BCVA improved from 0.04 to 0.03 logmar. There was statistical significant difference noted between the pre-op and post-op values, and similar can be seen in the following graph. The efficacy index based on the UCVA and BCVA were 0.98 and safety index was 1.04. Now the refractive stability was noted in the post-op period day 1 month and 3 month. As per the table, the diopter sphere, diopter cylinder and diopter spherical equivalent were in negative sign in post-op 3-month period, signifying that there were no overcorrections. And there was statistical significant difference between the pre-op and post-op values for all these 3 parameters also. Now this is a scatter plot of attempted and achieved spherical equivalent. And as we can see that there's a strong correlation noted as all the points lie along the trend line, and this shows high predictability for outcomes. The spherical equivalent refraction at 3 months within plus minus 0.25 diopter of intended refraction was seen in 83% of eyes, within plus minus 0.5 diopter seen in 95% of eyes, and within plus 1 diopter seen in 100% of eyes. One instance of suction loss during the femtosecond laser application was noted, and the procedure was abandoned. No significant complications were observed during the follow-up period of 3 months. Discussion. This is the first study that highlights the efficacy and safety of femto LASIK with Schwind-ATOS femtosecond laser system to correct myopia and myopic astigmatism in Indian population. The quick recovery of UCVA was attributed to the smooth and uniform corneal flap creation by Schwind-ATOS, which promotes faster healing and reduces post-op discomfort. The results of this study are similar to the findings of the other studies also. The excellent refractive results that we had found were due to key features of the Schwind-ATOS, that is, its ability to be customized. This attribute has enabled surgeons to modify flap sizes as per the specific requirement of each patient. The precision of Schwind-ATOS in our study is evident with the spherical equivalent refractions that we had found at 3 months, discussed before. The safety index of more than 1, that is 1.04, signifies that there was gain in BCVA line post-operatively. The advanced features of Schwind-ATOS noted were low pulse energy, that is high pulse rate of 4 megahertz, asymmetric spot spacing, and Centrax eye tracking system. So these features have helped to create smoother flap surface and thus improve the post-op outcomes. They have helped for quicker procedures and faster visual recovery. They've enhanced the efficacy of the procedure and helped in achieving refractive accuracy. As observed in our study, femtosecond lasers, including Schwindetor's, have helped in creating predictable and uniform flaps and has helped minimizing flap-related complications. The limitation of our study were small sample size and short follow-up of 3 months, which does not capture the long-term visual and refractive outcomes and complications. So conclusion, femtoLASIK using Schwindetor's is a safe, effective, accurate, and stable option for correcting myopia and myopic astigmatism in Indian patients. The study establishes Schwindetor's as a reliable method for refractive surgery in India with excellent visual outcomes and minimal complications. Thank you.
Good talk. You had any hypermetropes also in your study?
No, ma'am, all were myopia, myopic patients.
So you only lay emphasis on this particular machine doing very well with myopic.
Yes, ma'am.
But you have your experience with hypermetropes also?
No, ma'am. So there's a different software that needs to be installed for hypermetropic patients, which I don't think I think it's going on with this machine. It's not yet come in the market for hypermetropia.
Okay.
So I had a question. So you said the efficacy index was slightly lesser than 1, right? 0.98 or so. Normally we consider as 1 as
Yes,
the gold standard for efficacy index, although the amount of correction and the values at 3 months correspond to any other laser system that we have. So any specific reason for that? How come the efficacy index was slightly lesser?
Ma'am, this is a short-term study at 3 months. So if so we took 3 months as our endpoint because this is a new machine and we need to know the short-term safety and efficacy. If it has gone, like we now know that it is good. Now we will go on with the long-term studies and maybe then we can find, maybe then the efficacy might increase more than 1. But as of now it was 0.98.
But you had 100 cases, right? So it looks
100
like
eyes.
100 eyes.
Yes, ma'am.
Yeah. So did you compare any comorbidities or any kind of strata, because you are in Sadhguru?
Yes, ma'am.
So there was the follow-up was 3 months, and
Yes, ma'am.
did you find any difference in your study, and did you take that into account of the
Ma'am, as in between the patients?
the ablation results in any of these with any dry eyes or ocular surface issues?
Ma'am, actually,
You could have included
yes,
that
ma'am.
also in the study.
Ma'am, in our center, actually, dry eye workup is not a routine for refractive patients unless somebody actually shows symptoms. That is when we do it. So here we did not find, at least up till 3 months, we did not find any patient with obvious symptoms. So we did not measure it.
Yeah, but this is a very important point. Most of these patients, they use contact lenses and there would be some dry eye workup is very important.
Right, ma'am.
Thank you.
Thank you, ma'am.
Third speaker. Yeah.
All right, now can we have Dr. Manpreet Kaur, please? And the next speaker will be Dr. Manik Nicholson. Dr. Manik is here.
A very good morning to all of you. I'll be discussing our research on indications, safety and outcomes of circle pattern in small incision lenticle extraction. There are no financial disclosures. So refractive lenticle extraction is the newest modality in refractive surgeries, and what was often propagated is that there is no effective retreatment option. However, the circle pattern gives an option to convert the original small incision lenticle extraction cap into a complete flap, and the procedure consists of creating a lamellar ring, a side cut and a junction cut. The junction cut joins the original cap with the new incision plane to create one larger surface that can then be lifted as a flap, and excimer laser ablation can be performed for retreatment without the risk of creating multiple interfaces. So pattern D, in which the lamellar ring is adjacent to the smile pocket cut at the same depth of the pocket, has been found to be the most optimal pattern with easiest flap lifting in cases of post-smile retreatment. Clinical applications, it can be used for enhancement using excimer laser ablation, removal of a completely retained lenticule, and rescue in case of inadvertent operator error during flap creations. So our purpose was to evaluate the indication, safety and outcomes of circle pattern of retreatment. It was a prospective interventional study of cases undergoing circle pattern of retreatment after SMILE over a period of 7 years, conducted at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS, New Delhi. The outcome measures were uncorrected distance visual acuity, percentage of eyes within 0.5 and 1 diopters of refractive target, and loss of corrected distance visual acuity. The outcome was assessed at 3 months post-circle retreatment. In 7 years, the circle pattern was performed in 1.49% of our cases. 4 had intra-op cap lenticular adhesion and 8 eyes required retreatment for a manifest refraction spherical equivalent of 1.5 minus 1.5 plus minus 0.78 diopters. 3 eyes with suction loss during cap side cut with completion of laser treatment were used circle pattern A to just create the side cut. At 3 months, the uncorrected distance visual acuity was 20/20 or better in 93.3% and 20/40 or better in 100%. No eye lost corrected distance visual acuity. 93.3% were within the 0.5 diopter of refractive target. All were within 1 diopter of the refractive target. There were no intraoperative flap lifting difficulties or postoperative flap related complications. So just a case example, a 27-year-old female who underwent both eyes SMILE for minus 5.75 and minus 6 diopter sphere, minus 0.5 diopter SIL respectively in the right eye and left eye. At 2.5 years, there was a diminution of vision in the left eye with a manifest refraction of minus 1.25 diopter sphere and minus 0.5 diopter SIL. She was planned for left eye enhancement using circle pattern. And if you look at the parameters, these are the original SMILE parameters in which the cap diameter was 7.2 and the new circle pattern had a diameter of 8 mm with the incision position was superotemporal in SMILE, and we make a nasal hinge in circle pattern to avoid that cap side cut incision. And if you look at the lenticule optical zone, it was 6.2, so the junction cut has to be at the same diameter at 6.2, and the lower and upper depth have a delta of 15 microns each, so that you do not create multiple interfaces, and in case there is any decentration, you can account for that. So this is how the circle pattern works. A nasal hinge circle pattern applied using Visumax. Flap was lifted, no difficulties were noted, and excimer laser ablation using MEL was performed. So to conclude, circle pattern is a useful rescue tool for intraoperative suction loss, cap lenticular adhesion, and a safe and efficacious method for post-SMILE retreatment and enhancement. Pattern D is conventionally used. In addition, pattern A may be used as a rescue tool in cases with suction loss during cap side cut when the laser firing is completed and the suction loss occurs just at the last stage. Previous studies, there are only 2 studies that have reported safety and efficacy of circle pattern D. None have evaluated circle pattern A. Thank you for a patient hearing.
Very challenging and promising modality. How do you rate it with the enhancement after a femto or a microkeratome?
Lifting the flap is as easy. So we also anticipated that since there are 2 different interfaces that are joined by just a junction cut, there will be some resistance at least at the interface of the 2 cuts. It's not so. So I have unedited videos also. It lifts as smoothly as a femto flap, even years. So the last I performed in the last OT only 3 years after the primary surgery. And it's just like you are lifting a flap for a first time, which is a complete in toto flap. There are absolutely no difficulties. So that's very nice. And one more thing that we would like to say is that the cap does decrease in thickness with time. So it's not 120 that you have kept initially. So you should adjust your junction parameters, delta plus and minus, accordingly by taking into account the AIOS at the present time when you are doing retreatment after 3 years or so.
What do you take maximum to take up such cases as tenure? 3
Maximum.
years, you're saying?
We have done after 3 years, because usually when the patients undergo regression for an year or so, they make do with it and then they start complaining, and once they come to us, we always wait for 6 months for stability. So ranging from 1 to 3 years, we have a spectrum of cases, and there is no upper limit per se. Even after 5 years, if they come, I'll do it.
When you decide on an enhancement, what is the value of the refractive error you take up as for?
At least 1 diopter.
Even for 1 diopter, you'll go ahead?
Yes, definitely, ma'am.
And looking at again the surface disorders and all of that?
Yes, ma'am. And the uncorrected visual acuity, once it falls to 612, then it's an indication to go ahead.
now I invite Dr. Manik. Can we have your presentation, please?
Good afternoon, everyone. I will be discussing my free paper on the biomechanical responses to PRK in high and low myopia. It's a comparative analysis. Oh, sorry. Can we...
Slides.
Yeah. So the title of my free paper is the biomechanical responses to PRK in high and low myopia. It's a comparative analysis, and my co-authors are Dr. Krishna Pujata, Dr. Anubha Rathi, and Dr. Somashila Murthy. So corneal visualization using shine plug technology, or Corvus ST, represents a paradigm shift in leveraging ultra high speed shine plug technology in order to assess corneal biomechanical responses to a standardized air puff and to measure the deformation of the cornea. While there is a significant amount of literature which has already been published on corneal biomechanics in virgin eyes, especially in those post-LASIK and post-SMILE eyes, there still remains a lacunae in eyes who have undergone PRK surgery. Now, PRK is considered to be biomechanically more stronger than LASIK and SMILE, primarily because of its tissue-sparing nature. However, a significant gap still exists in the understanding of corneal biomechanics in highly myopic eyes. And this was something we attempted to address in our study, which aimed to understand the differences in corneal biomechanics between two specific patient groups, that is those with high myopia and low myopia following PRK surgery. Our hypothesis was that the inherently poor corneal biomechanical properties in high myopes might result in greater post-surgical changes in this cohort of patients. So it was a retrospective study conducted at the L.V. Prasad Eye Institute. We included all patients above the age of 18 with a stable myopia or myopic astigmatism, and those who had a normal or thin corneal pachymetry, as well as those with a mildly suspicious topography but who would otherwise be suitable for a laser refractive surgery. All the surgeries were performed by a single surgeon on an excimer laser at a frequency of 500 Hertz. MMC was used in a concentration of 0.02% for 10 seconds per diopter of ablation and was thoroughly washed after the procedure. And a standard protocol of postoperative antibiotic, steroids, and lubricants was followed. Prior to the surgery, all patients underwent a routine ocular examination, and topography was performed on the Pentacam HR. We analyzed, amongst other parameters, the apical pachymetry and thinnest pachymetry. This was done pre-operatively and then at 1 month and 3 months after surgery, and the difference was then documented as the delta change. In addition to this, the amount of central ablation on the excimer machine was also documented. So this is the Vinci-Guerra screening report from the Corvus machine, and the parameters which we analyzed over here were the DA ratio, the integrated radius, and the stiffness parameter A1 index. And these were taken pre-operatively and then at 1 and 3 months post-operatively, and the difference was documented as the delta DA ratio, the delta integrated radius, and the delta SPA1. So we analyzed 65 eyes of 33 patients, and the average age of our cohort was around 26 years plus or minus 3 years, with an equitable distribution amongst males and females. There was also a comparable distribution amongst the high and low myopes as seen here. So in high myopes, the correlation between the central ablation and delta SPA1 was found to be weak and insignificant. However, amongst the low myopes, we found a statistically a negative significant decrease in the trend, suggesting that an increase in central ablation was associated with a meaningful decrease in delta SPA1. However, there was no significant difference between the high and low myopes when comparing between these two groups. Similarly, in high myopes, the correlation between central ablation and delta integrated radius was weak and insignificant, suggesting that the occurrence or the trend could have occurred by chance. However, in low myopes, there was a significant positive correlation between central ablation and delta integrated radius, suggesting that greater amounts of central ablation were associated with a meaningful increase in delta integrated radius. However, there was again no significant difference found between the high and low myope groups. In low myopes, an increase in central ablation was found to increase the delta DA ratio in a significant manner. However, this again was not found in the high myope group. So the only parameter from the Corvus which we found significant between the high and low myopes was the delta integrated radius. The other two Corvus parameters, that is the delta SPA1 and the delta DA ratio, were not found to be significantly different for either central ablation, delta thinnest pachy or delta apex pachy between the high and low myope groups. So our conclusion was that subtle biomechanical differences do exist between high and low myopes, and their corneal response to ablation does follow a relatively predictable pattern. And these reports support the notion that PRK, when performed with appropriate adjuncts such as MMC, can be a safe and effective option for high myopes without significant additional biomechanical risks as compared to those to the surgery done in low myopes. Thank you so much.
So do you rate this as better than any of the femtolasics? In PRK, they were all PRK done.
Correct.
And what was the value of low myopia?
So we
Which
took a
had changes, which had more changes?
So in the low myopes we considered were those with a spherical equivalent of less than 6 diopters, and the high myopes more than spherical equivalent more than -6 diopters. And while we did find a trend towards correlations between a greater amount of central ablation and change in biomechanics in the low myopes, we didn't find significant trends of change in the high myopes. But when we compared the two groups, that is the low myopes with the high myopes, we found that the magnitude of change in one group compared to the magnitude of change in the other group was not statistically significant. So we could not at the end of our study say that there was any significant biomechanical change more in the high myope group than that which we would see in the low myope group. But again, our study number was small because PRK is not routinely done in very high myopes, though in our center we do quite aggressively do PRK in higher dioptric powers. So we thought we would look at this data retrospectively to see what we got out of it.
So this change was statistical only or clinical as well?
No, there was no, we didn't document ectasia in any of the patients. We just wanted to see whether any of them were responding differently to such large amounts of ablation.
What was the upper limit of the myopia?
We
You went
didn't
up
do
to?
anything more than 10 diopters of spherical equivalent.
Time duration for mitomycin C used for low myos, what is the lowest duration that you used it for? Was there a cutoff value? I saw the 10 seconds per
Correct,
diopter, but
yes.
usually we have
Yes. No, usually in our center for a diopter, it's surgeon preference. We might not use MMC. This surgeon did use MMC for the purpose of the, for at least for the patients who we were doing Corvus post-op, we ensured that we used MMC in all the cases.
Thank you so much. Can we have Dr. Tanvi Haldipurkar now?
Good morning, everyone. So my study was to look at the effect of cyclosporin A on refractive outcomes and epithelial remodeling post-topo guided LASIK. Now we know that epithelial remodels itself to kind of smoothen the ocular surface. This may happen in cases of LASIK or keratoconus or any corneal dystrophies. But how this pattern of epithelial remodeling is changing in response to laser vision correction and its effects on the visual outcomes is something we don't really know. Now we know that cyclosporin A is an anti-inflammatory and immunomodulatory agent, and a lot of studies have shown that it improves the tear production, enhances sensitivity, and shortens the duration of visual recovery after LASIK. But is there a role of cyclosporin in epithelial remodeling which is correlating with better visual outcomes, was something we don't know, and that's what we wanted to look at. So we compared two groups of eyes undergoing topo-guided LASIK, one which was treated with cyclosporin A postoperatively and one which weren't. And we looked at the following parameters of epithelial remodeling, visual outcomes, and higher order aberrations. So this was a retrospective study conducted for a period of 12 months, and we had a group A and a group B arm. And we looked at the epithelial remodeling in two groups with an AIOS20 of with looking at 25 sections. We looked at the visual outcomes with uncorrected and best corrected visual acuity and visual function questionnaire score. And we then looked at the higher order aberrations on a night race at a standard 4 mm pupil size. So we included all those patients undergoing topo-guided LASIK who were between 18 to 40 years with the mean spherical equivalent being less than or equal to -9. We excluded those patients with hypermetropic astigmatism and hypermetropia, any prior corneal surgeries, who had significant dry eye, prior use of cyclosporin, or any intraocular complications. Now, preoperatively, the visual acuity was looked, higher order aberrations from eye trace, epithelial thickness in 25 sections with an AIOS20. And post-op, we collected the data at 1, 3, and 6 months. Post-operatively, we found that the mean age in both groups were comparable. We saw that both groups had similar preoperative sphere and cylinder, and the spherical equivalent of the two groups did not show any statistical difference. When we looked at the epithelial remodeling in the central as well as 3 concentric zones on ASOCT, what we found is that there was a progressive thickening seen from the baseline, that is pre-op to 6 months, mainly in the central and the inner zones. The overall absolute epithelial thickness was less than pre-op for the middle and the outer zone. But as you can see, each of these zones was behaving very differently from pre-op to 6 months, and we didn't really understand whether was this epithelium becoming more uniform or not. And we wanted to know whether is there a uniformity that changes from baseline to the 6 months, and does it impact the visual outcome, and for which we derived a single measure, which is the epithelial uniformity index, and this metric quantifies the uniformity by penalizing the variability relative to mean thickness. So here onwards, when we use EUI as the index, you should know that the higher the value, that is towards 1, the higher would be the uniformity of the epithelium. So we now then looked at the two groups and looked at the epithelial uniformity index, and we found that there was a decrease in the EUI from baseline, showing that the uniformity drops after topo-guided LASIK. But what was interesting to note is that this EUI still remained very less at 6 months. So it shows that the epithelium never really recovers to its preoperative value even at 6 months time period. When we looked at the EUI across the different zones, we found that there was an equal drop in the inner and the middle zone, but there is a minimal change in the outer zone. Now this shows that the change in the epithelial uniformity was driven by the LASIK ablation zone, which is mainly centered in the inner and middle zone and not affecting the outer. We looked at both group A versus group B and looked at the uniformity index, and it showed very similar results like I showed before, that the inner and middle were affected and not so much the outer. Since both these groups were behaving individually very similarly, we have combined the graphs to show you a better correlation between EUI and other parameters. So we wanted to look and understand what is it that is changing or driving this decrease in uniformity, and we found that those eyes who had higher refractive errors experienced more change or reduction in epithelial uniformity. And at 1 month, when we looked at multivariate modeling, the EUI was mainly influenced by the spherical equivalent and the total higher order aberration. We also found a weak negative correlation between uniformity and uncorrected visual acuity at 6 months, and coma and uncorrected visual acuity shows a significant negative correlation, which means that if there is lower uniformity, the patient will experience greater coma and slightly higher logMAR, that means a lower vision. There were no correlations seen between the other parameters which we analyzed. When we looked at the visual outcomes, we found that group B, which is the cyclosporin group, showed better visual acuity, more number of eyes with more than 6.5 visual acuity. At 6 months, group B showed more eyes with line gain as compared to group A. Group B did better with respect to the visual functioning score as well as the OSDI score, but only the VFU was statistically significant. The higher order aberrations, group B showed better, but they were not statistically significant. And the change in higher order aberrations from 6 months to 1 month was shown to be greater in group B. That means there was a greater reduction of the total higher order aberrations, considering it was a topo-guided LASIK, and this change was statistically significant. So to conclude, the epithelial uniformity index is a good way to look at the changes which are affecting the corneal epithelium post topo-guided LASIK, and probably most other refractive surgeries, as epithelium is what we are changing. And epithelial uniformity decreases at 1 month, remains low right till 6 months, which is a concerning trend because post LASIK, and we need to look at long-term studies to actually see how and when does it ever recover. Lower uniformity is more common with higher refractive errors and those with higher total higher order aberrations. Lower post-op uniformity leads to slightly lower vision and higher coma in the short term. Again, long-term outcomes will be needed to be looked at. And adding cyclosporin to routine post-LASIK patients does not seem to help with epithelial uniformity, but it does give marginally better vision and ocular comfort, and its mechanism of action post-LASIK needs to be studied in further detail. Thank you so much.
Interesting topic. So finally, cyclosporin didn't stand any chance to do any alteration in the inflammatory mechanism.
So we've not really looked at that part of things because it has been well established that of course it does reduce the post-operative inflammation. We kind of looked at a different arm completely where we wanted to know, does it correlate with the visual outcomes? Does it correlate with the changes in epithelium? I'm sure if you would have looked at how it affects the inflammation or even the tear film, it would have scored better. But that's not the perspective we wanted to look in this study.
So, but then that's an established fact that
that's
the
right.
epithelial healing will be much dependent on the ablation,
Exactly.
on
Would
the
we depend?
powers.
Oh, you mean the refractive error?
Yeah.
Yes, but there has not been any study, to my knowledge, which says it that yes, it is the use of this or the use of a higher ablation causes direct association with the change in the epithelium. We know that there will be more progressive thickening. Maybe this is our assumption, but studies have looked at the mean epithelial thickness. So that is something which we also looked at review of literature. Most studies have said that yes, there is a thickening. The mean epithelial thickness in central zone would be much more if you do a higher refractive error as compared to the other. But an overall uniformity was not something that has ever been looked at.
So, what was the gadget you used for mapping it?
We looked at the AIOS2025-Free, we looked at all the 25 sections from the central, inner, middle, outer zone. And each of these sections, we also have the mean epithelial thickness. But looking at those 25 sections separately didn't really give you a picture of was it more uniform or was it disparate. If you map them on a color-coded image, some of them looked uniform, some of them not. But that was not a very good subjective method to look at. So
I guess the epithelial mapping machine we have now
Yeah.
would be more promising
Yes.
and would validate more
Probably. If they
on
use
the
some
figures.
sort of a statistical analysis like this,
For
we
this
would get
study.
it in a single measure that is it uniform or not. Thank you.
Thank you. Now I invite Dr. Zain Katib, please.
Good morning. So I'm going to be speaking on the impact of a new surgical instrument on topography-guided LASIK outcomes. So I have designed this very simple globe stabilizing instrument that you can see, which I use for LASIK. So it's got a head and it's got a handle. So the head basically has multiple blunt teeth to hold the eye still during ablation. And there is a flap hinge, LASIK flap hinge protector on top, which helps to protect the retracted flap during surgery. Okay, so we wanted to test out how the instrument works. So we did a retrospective analysis, which was a single center study where all eyes undergoing Contura femto LASIK over a period of 8 months were included. And we included all patients with myopia, myopic astigmatism less than 8 diopter spherical equivalent. Exclusion criteria were coexisting pathologies, extreme ages, BCVA worse than 6/9, patients not completing follow-up, and any flap-related complication. So after we reviewed our data, we found 210 eyes of 105 patients that were fit for the study, and there were two groups here. Group A was the control group where we did not use any instrument. That included 100 eyes done by a specific surgeon. And Group B was the study group, which included 110 eyes where the instrument was used during ablation. So we did a normal preoperative assessment of corrected distance visual acuity, refraction, contrast sensitivity using spatial frequencies, corneal aberrations using Scansys anterior segment analyzer and Topolizer Vario. Surgical technique was very standard for all the patients, Contura topography guided LASIK. The flap was done with a Zimmer femto machine, superior hinge, 90 microns, 9 millimeter flap diameter, ablation zone of 6.5 millimeter, and standard protocols of surgery. All the post-op assessments were done at 3 months with uncorrected distance, manifest refraction, corrected distance visual acuity, contrast, and corneal aberrations. Analysis was done using MedCalc calculator for statistics, and the standard refractive 9 graphs were used for reporting. If we look at the results, both the groups were matched well in age, gender, spherical equivalent, sphere, cylinder, and type of cylinder. So there were no differences statistically between these two groups. If we look at the primary outcome measure, the uncorrected distance visual acuity was significantly better in the study group where we used the globe stabilizer. The post-op spherical equivalent was not statistically significant, but the post-op residual cylinder was significantly lower in the group where we used the instrument. If we look at the refractive graphs, again we can see more percentage of eyes with better vision, 20/16, and more percentage of eyes with one or more lines of improvement in acuity, again in the group where we use the instrument. Efficacy index was also better. These are the spherical equivalent charts. These were not significant. But again, if we look at astigmatism accuracy, more percentage of eyes were within 0.25 diopter of residual cylinder. So 100% eyes were within 0.25 versus 75% where we didn't use the instrument. Now coming to a very important parameter, the higher order aberrations. So the induced total higher order aberrations, vertical coma and horizontal coma, all were significantly lower in the group where the instrument was used. Only spherical aberration was the same between the two groups. And this graphically shows the higher order aberrations. So whatever is in red is where the instrument was used. You can see all are, lower. You can see the dotted horizontal line, which is the 0. So anything below the 0 is actually improving the aberration. So vertical coma significantly improved post-surgery in the group of patients where we use the instrument. We also did a linear regression analysis for both groups individually to compare the main outcome measures with some preoperative parameters. And what we found in the group where we did not use the instrument, both the post-operative uncorrected vision and the higher order aberrations were significantly correlated with the pre-op spherical equivalent. So if we look at the graph, we can see in the group where we have not used the instrument, per diopter increase in myopic spherical equivalent, the higher order aberrations increased by 0.04 RMS. But when we did it for the group with the instrument, we saw that there was no such pattern. So this tells us that when we use the instrument, even in higher refractive errors, we are actually not inducing more aberrations as compared to not using this instrument. So just to conclude, by using a simple globe stabilizer instrument while ablation, we are significantly improving refractive accuracy and efficacy. We are inducing lesser aberrations. In some cases like vertical coma, we are actually improving the vertical coma from pre-op. And the induced aberrations increase for higher refractive errors. That also we have established when we are doing topography guided LASIK. But when we use a globe stabilizer, we are actually negating this effect. So in conclusion, we found that when we use the globe fixation instrument, we are improving our visual outcomes, and this is more so seen in higher degrees of ametropia. Thank you.
Interesting. When you put this globe stabilizer, does it need any kind of anesthetic drops?
No, ma'am. It's
How are you going to place it then? It will not hurt the patient?
no. So the teeth which are there are blunt. They are blunt enough not to hurt the patient, but at the same time they hold the eye very still during ablation.
Practically, we may use some Paracane or something like that.
So, ma'am,
that adds on to a little bit.
we have not noticed any discomfort the patient has felt while using it.
Okay. And what about the iris tracker? That is already there.
So yeah,
along
the
with,
iris tracker
it's
is there,
over and
and
above.
it is. We have extensively tested it that it doesn't affect the iris tracking at all. So the iris tracker, because it is a steel, it is not affecting with the iris tracking.
So it's a
at
double
all.
protection for
Yes.
an anxious patient.
Yes.
And of course, a central
So
ablation.
anxious patients and patients where the ablation is going on for longer time, it works really well because we are holding the eye still at that time.
And doesn't affect the ablation pattern.
It doesn't. It will only prevent ablation on the hinge if there is against the rule astigmatism. So that may affect it in some way, but it would be better than if the ablation would happen on the undersurface of the hinge.
Right.
Yeah, but to protect the, I think basically if you're not using, it seems unlikely you can use this without any anesthesia drops. And when you are using, basically what the design you have shown is, basically it is just protecting the hinge.
Yes.
And the tracker role is also very significant with the high-end machines, and you are negativating that.
No, ma'am.
So-
The tracker is working. What
Yeah.
happens is that if the patient moves, the tracker moves with the patient. But
Yes.
only thing is there's a small latency in the movement of tracker. So here, what we are trying to prove is that in spite of having a tracker, we are trying to make sure that the laser is fixated in the center and the patient is not moving.
Thank you.
Thank you.
So I think this instrument might have use in patients who have nystagmus specifically because those eyes it's very difficult. Sometimes the tracker even doesn't work, so probably the tracker would work better in this case. Maybe we need a multi-sector study to really evaluate the two better and to be able to understand how.
It's available commercially with Epsilon, so it can be tried.
To leave Vikita for another meeting. Can you just take over? Thanks.
Dignitaries and dear friends, Innovation, air bubble science to retrieve stuck lenticule in small incision lenticule extraction. There is no financial interest. Small incision lenticule extraction in myopia is the safest corneal refractive procedure available today. However, few issues related to the lenticle dissection need to be addressed, especially stuck lenticule when it is attached to the top cap, residual stomal bed, or femtolaser air bubbles if they are absorbed due to delayed dissection. As a protocol, dissection anterior to the lenticle is done first. Inadvertent dissection posterior to the lenticle will make it stick to the top cap. Possible reasons for stuck lenticule are thin lenticules, opaque air bubbles, poorly seen or perceived demarcation of femtolaser cuts. As per the literature, this is the first attempt to address the issue of stuck lenticule. The air bubble science will help to retrieve the stuck lenticule. 100 eyes of 50 patients were observed from January to June 2023, willing for minimum 6 months follow-up. In 2 patients, lenticle was stuck to the top cap. In 1 patient, femtolaser air bubbles disappeared due to delayed dissection as patient was not comfortable. This obscured the landmarks for the dissection of the lenticule. Air bubble pattern of femtolaser and atmospheric air bubbles were used for retrieving the lenticule. This is air bubble sign 1. As femtolaser air bubbles get absorbed, atmospheric air bubble will enter the cavity and it will surround the instrument, indicating surgeon is trying to enter a plane which has already been dissected. As you can see here, when he is entering, there is an air bubble which is surrounding the instrument, and now he knows that he has to dissect in another plane to retrieve the lenticule. Due to repeated entry in a dissected plane, the cavity gets filled with the atmospheric air. So if you put a instrument now repeatedly, you may not see air bubbles surrounding the instrument, but there will be no force to the instrument, there is no resistance, which can be seen in this video. As surgeon is trying to enter, there is no resistance at all, but now air bubble sign 1 is not seen. Air bubble sign 3, if the dissection of the lenticle is delayed, femtolaser air bubbles will disappear. You can take help of air bubble 1 and 2 to dissect this lenticle. As you can see on the right side, there is hardly any air bubble is seen. In the video, you will realize that there are no air bubbles which are seen even under high magnification. Air bubble sign 1 and 2 is used to do dissection and retrieve the lenticle. Retrieve the stuck lenticule, we use a blunt on sharp technique. A sharp instrument is introduced below the atmospheric air bubble. After entering correct plane, blunt instrument is introduced above the sharp to retrieve the lenticule. As you can see here, there is sharp instruments already there. Above that, we are putting the blunt instrument, entering the right plane, doing the dissection, and removing the lenticule. All 3 patients with 2 stuck lenticules and 1 without femtolaser air bubbles underwent successful lenticle removal with good visual rehabilitation. Air bubble signs help to locate the correct plane of dissection. Blunt on sharp technique help to retrieve the stuck lenticule. To the best of our knowledge, air bubble sign for dissection and removal of stuck lenticle has been described for the first time. In conclusion, air bubble signs help as a guide for the lenticular dissection. It helps to retrieve the stuck lenticule. Lenticular dissection becomes easier. Results are good with excellent visual rehabilitation. These are the references. Thank you.
Very fine presentation, Dr. Ladi.
Thank you.
And when you're talking about air bubble, so this particular is useful only in lenticule dissections?
Only in smile, ma'am. Smile.
In
surgery.
smile.
In smile.
And the air bubble, you're not injecting, it is the atmospheric.
See, as we dissect the femtolaser air bubbles, the outside atmospheric air bubble will enter inside. Many times what happens in thin lenticle or when you have opaque air bubble, you will not know whether you are entering anterior to the lenticle or posterior lenticule. Thinking that you are entering anterior to the lenticle, actually by mistake you can go posteriorly, then it's a little difficult situation. Then these signs will help. So this is the only hitch which is there into a smile surgery,
Correct.
Which we try to address, so that, it is a last thing which can be treated well, and then it's the safest procedure now.
And if the air bubble is not there at all, I mean, if in any of the any particular
Yes,
case,
so the third sign, as I said, that patient actually had a visual. So by the time first eye, right eye lenticle was taken out, he said that he started getting sweating. So anesthetist said you will have to wait. So we waited. And by the time I went to the microscope, there is no air bubbles. So there are no incision also was not seen. So then we located the incision from the direction where it was there, made a small nick there, and from there we use air bubble sign 1 and 2, because in that case you can go anterior to the lenticle also and posterior also. So air bubble sign 1 and 2 will help, and then you can remove this lenticle easily.
very.
But then you are saying when you went second time, there was no air bubble. So we understand that
No,
one sign
first-
you are saying that atmospheric air enters.
Yeah,
But what about the second?
first time when surgeon is going inside,
Yeah.
the femtolizar not there, atmosphere will go in. So it will surround it. But if you try it repeatedly, then cavity will get filled by the atmospheric air. At that time, it will not surround the lenticle as a second or third or fourth attempt, but there will be no resistance to the instrument, indicating that we have to go to another plane now.
Thank you.
Thank you. Thank you.
Thank you, sir. Now, may I please invite Dr. Bharti, sir, for his talk?
Good afternoon. I'll be talking on safety and efficacy of correction of myopic astigmatism with clear lenticule extraction. And clear is a new system of lenticule extraction, and the machine is manufactured by Zimmer of Switzerland, and I have no financial interest. And this is the video I want to show before we proceed further. So this is a normal lenticule extraction video. The beauty is that the pupil and the axis at 180 degrees is captured automatically. So this is the beauty of this system. If you mark at the limbus, it is even better. But if you do not mark, even then 180 degrees is reasonably well, acquired or captured. The posterior plane is dissected with the femtosecond laser, and then the anterior plane will be dissected. And if you go and see these two tunnels, here the arrow is not moving, but you can see those two tunnels at the top, the green and the blue, and they are the venting tunnels, so that there is no air bubble, going behind or anterior to the lenticule and having any difficulty. Regarding this separation, which you can see, I have separated both the anterior and the posterior, and once you separate the posterior, you can see the edge of the lenticule very well. So the definition of the anterior and posterior plane is not very difficult if you are doing a smile or a clear or whatever elita. So, and then you dissect it till the periphery, and once you have dissected at the periphery, if you have dissected completely till the periphery, then probably just a little bit of elevation in the spatula, and then moving the spatula circularly, it will bring the lenticule out itself. So there is no need to pull the lenticule, and there is no possibility of, any such tear or anything. But in here, this is the very old, almost 2 years back I did, and this is the lenticule which has come out, just to check whether it is a complete lenticule or not. So this study is probably the first study which shows the correction of astigmatism of up to 4.5 diopters by a lenticule method, which is very accurately possible with the clear system. And the topic will be like population and vision distribution, and total study population 50 eyes of 26 patients before surgery and after surgery, and how much vision was there prior to the correction. So in the pre-op refractive error, the spherical power was 0.75 to 7.25, and cylindrical was minus 1.5 to 3.5, and there were, three groups: the mild, moderate, and high astigmatism, and mild, moderate, and high refractive error. And in all these cases, we have analyzed that even in the higher astigmatisms, the correction was very nice. So this is what the data is. The post-op 1 week data shows 82% of the patients gaining a 20/20 vision in 1 week time, and then it is 1 month is 84%, and 3 months at 83% with 20/25 in 10% and 20/30 in 7%, and all these patients who were 20/30, few patients gained one line after that. Also, if we analyze RMS values, they improved in 93% in at 3 months, and average reduction is 16.4 units, and clear demonstrated surgical efficacy in reducing RMS values. Higher order aberration analysis with the 6 millimeter pupil, preoperative mean HOA was a 1.87. It improved in 30% and remained stable for 3 months. Increase in HOA was found in 27% of the eyes, which reduced to 22% at 1 month and remained stable thereafter. So what I want to say is a clear is a procedure which is very accurate in correction of the astigmatism as well as the correction of the refractive error of myopia, and also the vision is stable for long time, forever. After 3 months, this is a 3-month study. We are further studying the data at 6 months and 1 year. The beauty of the machine is that it captures the 180-degree axis, and then you can mark accordingly. So there is no need to, like in the iris the iris pattern capture in the excimer laser, this machine captures the axis at 180-degree very nicely, and that is why the astigmatism correction is, in other machines, the axis correction or astigmatic correction is not so accurate, especially in other machines where the capture has to be done manually and one has to rotate the cup manually. But here this is automatically captured. That is why this is a better system in all the femtosecond laser lenticule extraction systems. Thank you very much.
Innovative, sir, and I think it's very, very promising. Does it really have, a priority in a particular machine, or is it a software which can be incorporated in the other machines as well?
I'm not sure about other machines because this is a software which is there inbuilt in the machine. It's not something which I don't know about this because the whole thing is different. All other machines are not so fast, and also the pupil capture is also not automatic in any machine. So the centration, especially if you mark the pupil, and then you can mark the visual axis with the junction violet before, and if you mark the visual axis also, then it captures the visual axis, and lenticule centration is on the visual axis. So pupil centration, visual axis centration, axis marking is very accurate in all these.
So what was the maximum cylinder, sir?
I have done 4.5 cylinder in this machine myself, and with an excellent result. In fact, that particular patient gained 1 line.
And since it is 180 pic, so in oblique astigmatism, does it have the same efficacy? I mean, the way you said it is.
See, you have to mark the axis, and then automatically the lenticule is created according to the axis, whether it is oblique or horizontal or whatever. So it doesn't matter. Once you have marked the axis correctly, then oblique astigmatism is as well corrected. There is no problem on that.
So the numbers in your series, the high astigmatism was very less.
Actually, the number of high astigmatism patients is otherwise also low.
Yes.
Very few patients are having anything astigmatism more than 2.5. Majority of them are in the range of 1.5 to 2.5. So I think very few numbers. Of course, high astigmatism is and there are other limiting factors. when there is high astigmatism, the pachymetry and other things we have to be very careful about, because ultimately you are making the cornea thin. So we have to take accordingly. Yeah.
Thank you, sir. Now I invite Dr. Sneha for her talk.
Good afternoon, everyone. I'm Dr. Sneha. I'm here to present a paper on Smile Pro Unveiled, Initial Outcomes with Visumax 800 from 1500 eyes. I have no financial interest. The chief author is a consultant for Zeiss. So Smile has demonstrated safe and effective results for myopic astigmatism correction over the past 13 years worldwide. Visumax 500 was European conformity and US FDA approved for myopia ranging from -1 to -10 diopters and myopic astigmatism ranging from -0.75 to -3 diopters with a maximum spherical equivalent of -10 diopters. In September 2021, the Visumax 800 was launched. It is a second generation femtosecond laser for Relax Smile Pro. It comes with significant upgrades to the existing platform. It has swiveling laser and microscope arms, and it has a higher pulse frequency of 2 megahertz in comparison to the 500 kilohertz of Visumax 500. This drastically reduces the lenticule creation time from 30 seconds to less than 10 seconds. It also integrates the automatic centration known as central line and the cyclotorsion known as oculine. The purpose of this study is to evaluate the visual and refractive outcomes of Smile Pro in a cohort of 1,500 eyes treated with Visumax 800. This was a retrospective single center study of 1,500 eyes treated with Smile Pro by a single experienced surgeon at Netradama Super Speciality Eye Hospital, Bangalore. The inclusion criteria were age between 21 to 45 years of age with a CDVA of 20/20 or better, with pre-op myopia ranging from -1 to -10 diopters and astigmatism ranging from -0.5 to -4 diopters with a total spherical equivalent of -10 diopters. Patients with severe dry eyes, corneal pathologies, cataract, glaucoma, retinal pathologies, other ocular disorders, and patients who were on immunosuppressants and pregnant individuals are excluded from the study. All patients who underwent they underwent a complete ophthalmic assessment preoperatively, and the manifest refraction was repeated on the day of the procedure. Follow-ups were on post-op day 1, 2 weeks, and 3 months. So 98% of the patients had a UDVA of 20/20 or better, giving us an efficacy index of 1.01. 18.4% of the patients had a gain of 1 line of CDVA, whereas 72.4% had no change. 9.2% had loss of 1 line of CDVA. Out of this, 78.9% of them still had a CDVA of 20/20 or better, and no eyes lost more than 2 or more lines. 99% of the patients had a spherical equivalent within plus or minus 0.5, and 100% were within plus or minus 1 diopter, giving good accuracy. The mean change in the spherical equivalent at 3 months was 0.016, which gives good refractive stability. Astigmatism, 98.5% of the patients had less than 0.5 diopters, and 100% were less than 1 diopter. The OSI, average pre-op OSI was 0.73, and post-operatively it was 0.84. We had a 12-month follow-up of 386 eyes. The rest were lost to follow-up. This shows that the UDVA was 95%. In 95% of the patients was better than 20/20. And 87.8% had UDVA same or better than CDVA, and 98.7% had UDVA within 1 line of CDVA. 5% had a gain of 2 or more lines, 36% had a gain of 1 line, and 51% had no change, giving us a safety index of 1.06. The spherical equivalent refraction accuracy shows that 99.2% were within plus or minus 1 diopter, and the 2.7% had a change of more than 0.5 diopter in the pre-op refractive stability as compared to the pre-op, and refractive astigmatism was 100% in less than 1 diopter. So our study showed that 98% of the eyes had a UDVA of 20/20 or better, and 99% had a spherical equivalent within plus or minus 0.5 diopters at 3 months. Other studies with a smaller cohort by Einstein et al. And Sard et al. Showed 91% and 93% of eyes within 20/20 UDVA, and 86% and 91% with a spherical equivalent plus or minus 0.5 diopters at 3 months. This could be because of the laser optimization at our center. 18.4% showed a gain and 9.2% reported loss of one line in 3 months. This was comparable to Reinstein et al. Showing gain of one line in 15% and loss of one line in 8%. 98.4% had a residual astigmatism of less than 0.5 diopters. This is attributed to the Oculine software. Safety index was 1.6 and efficacy index was 1.01, which is an improvement from the Vigimax 500. The study which showed a safety index of 1.11 and efficacy index of 1.06 at our institution, and another study by Musharraf et al. Showed a safety index of 1.12 and efficacy index of 0.95 with the Vigimax 500. Mean change in OSI of 0.11 was seen at 3 months. Suction loss rate was 0.06%, that is one eye, compared to the 0.5% in Vigimax 500. This shows an 88% reduction in the suction loss rate. The only limitation was a 3-month follow-up, but previous research has indicated that the refractive stability is typically achieved within this time frame. So due to the large sample size, it's safe to assume that the outcomes observed are more reliable and statistically sound. To conclude, Vigimax 800 is safe and effective in treating compound myopic astigmatism with robust results, including excellent visual outcomes and refractive stability. Thank you.
So good amount of patients you have, and your results are very good. So what was the upper limit of astigmatism that you
4
went?
diopters, ma'am.
Thank you.
Thank you.
Thank you. I think we should move on in the interest of time. Do we have Dr. Nishika Jain? Yes, can we please have your talk?
Good afternoon, everybody. I will be presenting my free paper on central line software validation, achieving optimal visual access centration with the Vigimax 800. The authors are consultant at Carl Zeiss Meditech. So the first step, it begins when we take the location of the corneal vertex calculated in reference to the pupil center, right from the atlas. The next, we enter that data into the Vigimax 800. Then when the treatment starts and as the eye approaches the contact glass, the pupil edge is identified and it is displayed as a blue dotted line. The central line then displays the vector difference between the corneal vertex and the current position of the treatment zone. Our aim was to validate the accuracy of the central line software, which is the centration guide that allows the surgeon to center the treatment on the visual axis in myopic eyes treated with small incision lenticle extraction using Vigimax 800. Our objective is to measure the deviation between the achieved and the attempted centration. The study included it was a retrospective analysis of 114 consecutive eyes enrolled in the study at the Netradhama Super Speciality Eye Hospital. All the surgeries were done by a single surgeon. The patients underwent SMILE with central line centration software of the Vigimax 800 femtosecond laser. The vertex of the coaxially fixated eye was aligned with the visual axis. In cases with large angle kappa, the surgeon centered in between the visual axis and the pupillary axis. The optical zone was then identified on the tangential topography difference map as the central zone up to the mid-peripheral power inflection point on the atlas. The best fitting circle and the central grid were superimposed on the optical zone to determine the location of the optical zone center with reference to the corneal vertex. Here we can see how the pupil margin is defined by the blue dotted line. Then you get the pupil center with the center blue cross and one yellow dotted line with the center green fixation light where the patient fixes. On starting the treatment, the central line measures the the pupil margin of the blue cross, pupil margin of the pupil center. The XY coordinates of the corneal vertex with respect to the pupil center is measured on the topographer and entered into the Vigimax 800, which is seen as the yellow dot. The patient then looks at the green blinking light and the green fixation light is connected. Here you can see in the video, now the green blinking light will be connected to through the yellow dot. Now as the centration is achieved, the dot becomes yellow. The green fixation light becomes a yellow dot. Now as the yellow dot will turn blue when the treatment is within 200 microns of the corneal vertex, and then the docking is done. The central line thus guides the surgeon to center the treatment. The blue dot consequently becomes smaller as the centration is moved closer. Methodology: a tangential curvature preoperative and the postoperative 6 months difference map was generated for each eye using Atlas 9000. The fixed grid was superimposed onto the difference map to measure the offset between the center of the lenticule and the visual axis. Looking at the results, we can see the scatter graph combining the difference between the center of the deviation of the center of the lenticule from the visual axis. Here you can see this separately. The first graph shows how the lenticule center is very close to the vertex apart from few outliers, which was because of the large angle kappa. 64% of the eyes were within 0.3 microns and 98% were within 500 microns. Similarly for the y-axis as well. The p-value was 0.916 for the x-axis and less than 0.01 for the y. The mean deviation achieved was within 215 microns from the attempted centration. The significant decentration of the y coordinates is attributed to the surgeon's method of aligning of the center between the pupillary axis and the visual axis in cases of large angle kappa. My references. Thank you.
Have you validated your results with any similar studies?
Similar, Dan Weinstein's study was there. They have also had similar results, and there was one more study of Liu et al. They have also concluded that there was a difference of around the center has been deviated along the y-axis about 200 microns.
Thank you.
Thank you.
Thank you. Can we have Dr. Viraj Padwal here, please? Do we have Dr. Viraj?
Good afternoon, everyone. Today I am going to discuss about novel use of Circle software for management of epithelial ingrowth after smile surgery. I have no financial interest. Also, I would like to put this on record that we have already published this paper in a prestigious journal, so this will not account for any competition. So in this case, a 35-year female who was referred to us with the chief complaints of gradual painless progressive diminution of vision for 3 months in her right eye. The patient had undergone uneventful smile surgery 3 months back elsewhere for refractive error of -3.5 diopter. The diminution of vision began 1 week after smile surgery in her right eye. On presentation, her corrected distance vision acuity in her right eye was 6/36 with mixed astigmatism. Her left eye uncorrected vision acuity was 6/6. So on slit lamp examination, an area of epithelial ingrowth which was significant, and it was in a visual axis. The confluent epithelial nest were limited to the central cornea, and there were no peripheral extension toward the smile incision. The incision edge appeared to be intact and devoid of epithelial fistula, which was confirmed by fluorescence staining. So in this case, as you can, which was again confirmed by on AIOS2025-Free, showing hyperreflectivity at the interface. And significant topographic changes. So the mechanism of epithelial ingrowth could be postoperative migration of epithelial cells from incision toward the visual axis, loose epithelium at the smile incision, progression through epithelial fistula, and intraoperative implantation of epithelial cells during lenticular dissection, resulting in isolated epithelial nest away from the incision. So most of the reported cases of epithelial ingrowth after smile have been non-progressive and self-limiting. In literature, only 2 cases of progressive epithelial ingrowth after smile surgery have been reported, and in both of these cases, they have tried manual epithelial debridement to original smile incision, and there were recurrences noted. So, how to plan in this case? The epithelial ingrowth was localized and restricted to the visual axis with no peripheral advancement towards the incision. Using the same incision for debridement would have increased the possibility of reimplantation, because the epithelial cells were implanted to the original smile incision, as there was no fistula. A smaller smile incision cannot provide complete access for thorough mechanical debridement of epithelial nest, underlying stroma, and flap undersurface as well. So Circle software is a specialized software traditionally used as an enhancement tool. It allows conversion of smile cap into the flap, which gives access to the interface. So this is a donut-shaped femtosecond laser, creates a lamellar ring, the ring-shaped extension of the existing surface cut. It creates a junction cut to the new incision to the older one. So, and it does not add any additional laser to the interface. So in this video, as you can see, a donut-shaped femtosecond laser is being applied, converting smile cap into a flap using Circle software. We are carefully dissecting and lifting the flap to gain a complete access at the interface ingrowth. And then the ingrowth is gently debrided from the both the sides, underlying stroma and the flap under surface as well. We have used mitomycin C and absolute alcohol to make sure complete killing of the cell nests. Replacing the flap, again we are viewing this on a slit lamp view of Visumax to make sure the complete debridement of the epithelial cell nest. So as you can see, there is a significant improvement in topography as well as in a corrected distance visual acuity to 6/9 with -1 cylinder only. So with this same novel approach, 2 more cases have been treated at LV Prasad Eye Institute. We have clubbed this all 3 cases and published in a reputed Journal of Refractive Surgery. So here we report a novel therapeutic indication of Circle software to manage epithelial ingrowth, as it facilitates cap to flap conversion and consequently provides complete access to the original interface. After creating a flap, we could achieve necessary access to the isolated interface epithelial ingrowth and ensure its complete removal without recurrence, which may not have been possible through the smaller primary smile incision. Hence, employing the Circle software to successfully treat the vision-threatening epithelial ingrowth after smile provides a novel and unique approach leading to the optimal results. Thank you.
So this is not for the competition, you said. So do you advocate this technique for all the ingrowths? Because doctors have attempted through the same smile incision also. So when do you say that we should use this circle and then make a flap, and or should we try through the same smile, the ingrowth?
Majority of the epithelial ingrowth are non-significant and non-progressive, but if it is in a visual axis and it is affecting the patient's
Definitely. You have also shown the other 2 cases which was done in LV Prasad, which was quite. So you advocate that we should make it a flap and then remove instead of going through.
Yes, ma'am. To create to gain a complete access, here we can debride the
on the back side
and the back side of the flap as well with this method.
Yes, thank you.
Thank you.
Thank you. Can we have Dr. Sanjari Malhotra, please, for her talk? Is the next speaker here Dr. Nikit and Dr. Divya? Yeah. Yes. So meanwhile, while Dr. Sanjari uploads her presentation, can we have Dr. Nikit Sarvate?
So good afternoon, everyone. I'll be presenting a pre-paper on to study the outcomes of topo-guided advanced surface ablation with accelerated UV cross-linking in keratoconus. No financial interest to disclose. So ours was a retrospective case study performed between March 2019 till December 2023 at a tertiary eye care center in Satara, Maharashtra, India. 55 eyes of 31 patients aged between 18 to 32 years were included in the study. The parameters compared were uncorrected visual acuity, best spectacle corrected distant visual acuity, keratometry values measured on pentacam, pre and post treatment astigmatism, pre and post treatment Scheimpflug topography maps, pre and post treatment aberrometry, particularly higher order aberrations. The patients included in the study were patients diagnosed with progressive keratoconus grade 1 and grade 2 on Amsler-Krumik classification. Patients' corneal topography demonstrated keratoconus on pentacam with progression in the past 12 months and which met one of the following criteria. The increase in Kmax by greater than 1 diopter, or increase in astigmatism by greater than 1 diopter, or best spectacle corrected distant visual acuity reduced by more than 1 line. The patients excluded in the study, excluded from the study were patients less than 18 years of age, thinnest pachymetry value of less than 465 microns, previous history of any refractive surgery, herpes keratitis, or any other ocular disease other than keratoconus affecting the best spectacle accredited distant visual acuity, the women in pregnancy or lactating period. The surgical procedure, mechanical debridement of corneal epithelium after marking with 9 mm epithelial refine was done, followed by a topo-guided advanced surface ablation using a wavelight IQ exam laser system. The maximum laser ablation depth was restricted to less than 50 microns with optical zone of 6 millimeters, and minimum pachymetry cutoff of 465 microns at thinnest point was used for all of our cases. The laser ablation was followed by accelerated cross-linking for 10 minutes at 9 milliwatt per centimeter square using intact axial cross-linking system and Peschke H riboflavin solution. After cross-linking, a short bandage contact lens in diluted preservative-free ketorolac was used and applied until full epithelialization, and it was removed after 72 hours. Now coming to results, there was statistically significant difference in uncorrected as well as best spectacle corrected distant visual acuity between pre-operative and post-operative comparisons. Best spectacle corrected distant visual acuity not only improved significantly from baseline to post-operative 1 month and 6 months follow-up, but also remained stable till post-operative 12 months follow-up. At post-operative 1 month follow-up, best corrected visual acuity improved by 1 lines in 35 eyes, 2 lines in 20 eyes, and at post-operative 6 months, best corrected visual acuity improved by 2 lines in 40 eyes and by 3 lines in 15 eyes. Best spectacle corrected distant visual acuity remained stable in all the eyes at 12-month follow-up. This is a chart showing the improvement in post-operative distant visual acuity. So Kmax decreased significantly at all post-operative visits compared to the pre-operative value. At 12-month visit, mean Kmax decreased to 53.13 plus minus 4.47 adapters as compared to the pre-operative mean of 57.23 plus minus 5.09 adapters. Although the overall difference in keratometric values, keratometric follow-ups were significant, only values at 6 and 12 months follow-ups were statistically significant as compared to 1 month values. So corneal higher order aberrations and coma decreased significantly at post-operatively 1 month and decreased continuously until 12-month follow-up. So as we limited our maximum corneal tissue ablation to 50 microns, it was not necessary to use mitomycin C after the combined procedure, and there was no persistent corneal haze in any of our cases. Our pachymetry cutoff was 465 microns, which ensured that residual corneal thickness remained greater than 400 microns in all of our cases. As the ultraviolet A exposure time required in accelerated cross-linking is shortened, it also improves the treatment efficiency and increases the patient's compliance. So there are a few case scenarios comparing the pre and post-operative visual acuity, this pre and post-operative topography at 3-month follow-up. So to conclude, our study not only showed significant improvement in best spectacle corrected distant visual acuity, keratometric values, and RMS of higher order aberrations and coma, but also showed good stability in refraction and corneal curvatures after simultaneous topo-guided ASA with accelerated cross-linking, especially when used in early keratoconus. Regularization of the corneal surface post-operatively improved spectacle subjective acceptance as well as the contact lens fitting in all the cases. Therefore, our combined treatment protocol is convenient, time-saving, and effective and safe. It should be strongly considered in cases with early keratoconus in which the thinnest pachymetry values are greater than 470 microns, and when the apex of the cone is within the central 6.5 millimeter optical zone. Thank you.
So very good results. And but why have you not used mitomycin C?
Ma'am, because we restricted the ablation to less than...
That is all right, but
yeah.
most of the studies which are published,
yes.
they all advocate the use of mitomycin
yes.
further. And how did you remove the epithelium with the trans?
No, we have removed it mechanically, ma'am. Okay. For initial part of our study, which I haven't included in this, we had used alcohol, but what we observed in our practice scenario was in keratoconic, as such, the epithelium is very loose.
Yes.
So it can come off very easily.
Yes.
So
definitely, as long as you don't create any ridges.
Yes.
Thank you.
Yeah.
Thank you. I think they are asking us to wrap up. So can we, sorry to interrupt the discussion, can we have Dr. Sanjari please for her talk? And Dr. Divya, I hope your talk is uploaded and ready.
Okay, so good afternoon all. I'm going to be talking about the biomechanics and how it's integrated with the lenticular extraction in predicting our post-operative outcomes. So this is a brief set of what I'm going to be talking about today, coming a little on the introduction and a couple of scenarios that we see in day-to-day operative basis, where a case one with a similar corneal topography, similar refractive error patient undergoes a CLEX procedure, and then we see that on the post-operative day one, both of them have clear corneas and a good visual acuity. One has a wow effect and the second one does not have a wow effect. So we wonder that why is there a variability in this visual outcome? So when we look into the intraoperative parameters, like an opaque bubble layer, which in case 1 was minimal and in case 2 it was a dense opaque bubble layer, which again led to an easy dissection, which led to the wow effect, and the dense opaque bubble layer led to a tough dissection leading to a suboptimal visual recovery. So on the literature review, a little bit on the ease of dissection, we know that the corneal deformation is directly proportional to the ease of dissection. So higher the deformation amplitude, it correlates with increased difficulty in the intraoperative dissection and parameters. And we can grade this as 1, 2, and 3 as mild, moderate, and severe. And as we all know that the opaque bubble layer forms due to trapped gas bubbles during the femtosecond cuts. And literature also shows that it's more common in steeper, stiffer corneas. And so this comes to a question where we have a knowledge gap, that there is literature which is lacking information regarding the correlation between biomechanics and OBL formation, and the ease of dissection and OBL formation, what impact does it have on our postoperative outcomes. This led to our research questions. The first being, can we predict the OBL based on preoperative biomechanics? And the second one, can we predict the ease of dissection based on preoperative factors and the opaque bubble layer and their impact on outcomes? So this was our workflow that we did. It was a prospective interventional study at Narayana Nethralaya. 150 eyes undergoing lenticule extraction were evaluated. Preoperatively, topography, biomechanics, and stiffness were evaluated. And intraoperatively, the OBL grading and dissection ease was seen, and postoperatively, the quality of vision and recovery were evaluated again. So coming to the results. So we developed a custom software which analyzed the intraoperative images, and it quantifies the OBL using a bright spot area, which is usually seen on the posterior surface of the lenticule, seen by the aura. Based on this, we classified the OBL from grade 1 to grade 4, grade 4 having the dense opaque bubble layer. And we saw significant correlations between the OBL and biomechanical parameters. So a higher SPA1 and a stiffer, thicker cornea and a lower CBI were associated with a denser opaque bubble layer intraoperatively. So using a logistic regression, we achieved a high predictive accuracy using these parameters as predictors for different grades of OBL. And this was assessed through the ROC curve analysis. So it helps in identifying high-risk cases like dense OBLs, which made us think if we can build an AI-based model for OBL prediction. So where we can input features used in a random forest model, like the pentacam corvus, acusimics, lenticule, OBL, the BAD-D values, ease of dissection, everything we put into this to predict the ease of dissection during the lenticule extraction. So it's a machine learning algorithm which we fed the model with the input data, and it generates your multiple trees to give the results. So this confusion matrix, it shows how our model predicted the ease of dissection. Overall, we see a very high predictive accuracy for the moderate dissection, which is 89.7%. So it helps us differentiating borderline or challenging cases. And also the scatter diagram, it illustrates a positive correlation between the opaque bubble layer formation and the toughness of the anterior dissection, where the correlation factor is 0.65. So we see that in a dense opaque bubble layer with a tough dissection, visual recovery was slower, likely due to stromal inflammation and edema, with a no wow effect on the postoperative day 1. And in contrast, if we see a minimal opaque bubble layer with loose dissection, it results in a faster healing process and better clarity as by the post-operative day 1, where we can get the desirable effects. So this helps us to look into the future directions, where we can see that if we have a lower corneal stiffness with a minimal intraoperative OBL and loose dissection, it can lead to much smoother surgeries. And in contrast, if you have a higher stiffer cornea, a dense opaque bubble layer, you will have a tough dissection. Based on this, we can actually customize our laser settings based on these biomechanics preoperatively, which can give us a more precise outcome post-operatively. So we have to move towards a more precision refractive surgery model. So just to conclude over here, what we knew was that the grade of dissection usually varies with our corneal deformation, and opaque bubble layer is a common complication seen in lenticular procedures. What we actually learned was that the grade of the OBL and the grade of dissection are related to the biomechanics of the cornea, like the SPA1, CBI and TCT, and the dense opaque bubble layer leads to a no wow effect and a very suboptimal visual recovery. So in the future, this can become a milestone in customizing our laser treatments for lenticule surgeries in the future. Thank you.
So we will go on. It is very interesting. So have you made a model of this? Have you?
Yes, ma'am. For those 150 eyes, we have done the AI prediction model for that.
Okay.
Yeah.
Other than that, you people are not like
No, ma'am. We're planning to. It's an ongoing study. So 150 eyes till now, but we're going to be working on a larger sample size.
Thank you.
Okay.
Thank you. Now I invite Dr. Divya Vani for her talk on ICLs and IPCLs.
Good afternoon, everyone. Welcome to AIOS. My study is on comparison of phakic IOLs size and postoperative vault height with predictive formulas and anterior segment ocular coherence tomography. So phakic IOLs are the IOLs implanted in phakic eyes for correction of refractive errors where the corneal based procedures are contraindicated. But with these lenses, the sizing always remains a challenge because the white-to-white correlation to sulcus is imperfect, and relative to the limbus, the sulcus is on average 0.42 mm longer than the white-to-white, and the sulcus to sulcus distance is variable in a given eye. So can prediction formulas on AIOS2025 will help us to overcome this challenge. So apart from the anterior chamber depth and white-to-white, there are different parameters in the anterior segment. Here we could see that the distance between the scleral spur to scleral spur, which is known as anterior chamber width, and the distance between the angle recess to angle recess, correcting the distance to the crystalline lens is known as crystalline lens raise. So based on all these parameters, the predictive formulas were formed, like NK and KS formula, which are there on AIOS2025, which will predict the size of the ICL and the postoperative vault out for that given eye of the patient. So a total of 40 eyes underwent phakic IOL implantation, 20 eyes IPCL and 20 eyes ICL. It's a retrospective study where the preoperative AIOS2025 was done to document the predicted ICL size and postoperative vault height through NK and KS formula. All patients white-to-white was taken from digital calipers by a single surgeon. IOLmaster 700 and pentacam was also done. Postoperative vault height was calculated at the end of 1 month. So these are the inclusion and exclusion criteria. So coming to the results, the baseline parameters of spherical equivalent and K readings were comparable in between these two groups. So coming to the white-to-white parameters, the white-to-white measured by the digital caliper and by the white-to-white measurement of the pentacam were almost similar, but whereas the white-to-white measurement by IOLmaster 700 has overestimated compared to the other two. Coming to the size parameters, the size of the ICL that is calculated by the manufacturer was more compared to the NK and KS formulas which was predicted on the AIOS2025, but there was no statistical significance. So here we could see in each and every patient, the NK and KS formula has predicted the smaller ICL size than the actual nomogram. But in IPCL, we know that it comes in a different 0.25 increments, but the AIOS2025 predictor formulas can give only 4 different sizes, so the exact comparison could not be made. But in most of the patients also, in IPCL group also, the prediction formulas tend to select a smaller size than the actual nomogram. So coming to the vault height, the postoperative vault calculated at the end of 1 month was higher than compared to the NK and K's predicted postoperative vault height. So 2 eyes in group A and 4 eyes in group B has higher vault height, more than 1000, and 2 eyes in group B had lesser vault height. So when these patients were analyzed separately, we could see that in patients where the postoperative vault height was more, the NK and Ks formula has predicted one size lesser. Whereas in patients with a lesser vault height, the NK and Ks formula has predicted one side more. So in higher vault heights, NK and Ks formula preoperatively predicted lesser lens size compared to the implanted size, and in lower vault height, NK and Ks formula preoperatively predicted the higher lens size compared to the implanted side. The crystalline lens size and postoperative vault height has a strong negative correlation. So the limitations were a retrospective nature, small sample size. So a prospective multi-center clinical trial is necessary. The pentacam device was closest to digital calipers in white-to-white measurements. In addition to the traditional methods referring to the NK and Ks formulas can lead to a more accurate and predictable outcomes, mostly in the borderline cases, and when to plan the other eye. Conducting more prospective studies with a large number of patients can help improve the formulas to develop a better algorithm. Thank you.
Thank you. It's a very important study actually, because so many new formulas, AIOS2025 based formulas, have now come in to calculate the vault. So I just wanted to ask, did you rotate the ICL, or was it a toric ICL in the cases where you had vault more than 1000, or did you exchange that ICL? What was the management? You had 2 cases, right?
We rotated in one patient where the both eyes has done, but still it was the same.
Okay. All right. And the other eye, was it exchanged or it was just monitored? The IOP was okay?
IOP was okay, it was monitored.
Okay. And NK3 was used in our study because NK formula has also undergone so many changes.
Many changes.
Yes.
But the present which was there in the cassia.
Okay. Thank you. Thank you.
So thank you. We come to the end of this session. Thank you.